Good evening, everyone. We'll get started. Ready to get our program started here? All right, welcome everybody here to the Heartland Institute's wonderful Andrew Breitbart Freedom Center on a cool evening. The evenings are starting to get cool if fans of jackets like myself. I have a lot of nice ones I like to wear when it gets this weather, so it's kind of nice to see that as well. And speaking of weather, our speaker tonight came from Minnesota, and she had snow on the ground when she woke up, so we have that to look forward to at some point in the future. My name is Jim Lakely. I'm the Director of Communications here at the Heartland Institute, and we put on one of these events once or twice a month, and to talk about public policy, in policy that advances freedom and liberty. And we knew everybody in this room and watching online believes in those principles as well, and so I'm glad you're here to share the evening with us. Just a few things about Heartland Institute. If we have some new people here. We're a 34-year-old free market libertarian / conservative think tank. We were founded in Chicago and have been in this building here since 2015, which we're able to have terrific events like this. And we're just fighting for individual liberty and free markets. We work very closely with state legislators. Last night's election was a mixed bag in a lot of places, probably less mixed for a lot of state legislatures, which were much more dominant in the Republican side, but Democrats have made some gains there. But we're a nonpartisan organization, and we work with anybody in the state legislature who believes in advancing free markets and more individual liberty, and we will continue to do that. You may have, some people in this room may have been to our benefit dinner last Friday night at the Cotillion. Anybody here that was there? About half the room, about so. It was a fantastic event. We had as our keynote speaker Judge Andrew Napolitano. I had not seen him speak before. Like many of you, I'd just seen him on Fox News giving his opinions on things. Sometimes opinions I didn't like. Sometimes opinions Nancy certainly didn't like. And he was a fantastic speaker. It was just great. Unfortunately, if you were not there live, we are not going to be able to show you the video of his presentation. It's one of those deals where, as a contingency of bringing him to the event, that we're not allowed to publicly share and post on Facebook, or I'm sorry, on YouTube, his remarks. Well, I'm told not to do that, Nancy. Now, I do want to be sued by Andrew Napolitano.
That's how I saw what he did. They gave the same speech and everything else.
All right. Well, I'm telling you what my contract is. My point being, Nancy, like you, if you really want to get the good stuff that the Heartland Institute has to offer, you got to be there in person, like you're being here tonight and watching online. It was a fantastic night. Joe and Diane Bast, Joe, the founding president of the Heartland Institute, and his wife, who followed immediately after him in the organization as our financial manager and executive editor, received the Heartland Liberty Prize. It was a moving presentation to them. It was just made everybody in the room, the 400 plus that we had there, feel really great. And of course, Joe Walsh from AM 560 was our master of ceremonies. So you're able to see all of that if you missed it, except for Andrew Napolitano, on our YouTube page. Very easy to find. A couple of things that the Heartland Institute's been doing lately. We have something we call the Climate Disruption Project. It's a four-part series, and it's to, disrupt the climate alarmism movement, even among our friends. Our first event on that was to go to the American Enterprise Institute, where they were having a discussion about, was it carbon taxes, Tim Huelskamp? Yeah, in support of taxes on carbon dioxide as a way to mitigate man-caused climate change. And there was going to be nobody on the panels and nobody in the audience that was going to challenge that from one of our friends on the right. So we sent James Taylor, our senior fellow, and he challenged them. That was part one. Part two was San Francisco. That's right. I went to that one. I don't remember. There was the climate. Al Gore was organizing the Global Climate Action Summit in San Francisco. And again, if the Heartland Institute doesn't go out there to counter that kind of nonsense, nobody will. So we decided to go out to the Bay Area and have our counter event with real scientists talking about what the real data says and what's really happening with our planet. And you can see that at Heartland's YouTube page as well. Part three, we're going to join our friends in Europe, in Germany, Munich, Germany, to participate in a climate conference among climate realists. and real scientists who are trying to determine what's happening, not just to try to justify taking over economies and taking away your freedom based on the idea that humans are causing a climate crisis. And then the fourth thing is actually really exciting, not just because I get to go, but because every year the United Nations holds what they call the Conference of the Parties. And that is basically the big United Nations climate conference. And again, it's not really a conference. They just gather to decide how they're going to take your freedom away, how they're going to manage your economies. And again, if the Heartland Institute doesn't go there to give them the truth, nobody will. So we're going to Katowice, Poland, where the COP24, as they call it, will be held, having our own counter-programming. You'll be seeing a lot more details about that early next week. And again, a lot of that's going to be, all of it is really going to be recorded. You can see the great work that we're doing, not just here in the Arlington Heights and the Illinois area, but all over the globe. So that's all very exciting stuff. And again, last night's election was a little bit of a mixed bag, you might say. But the Heartland Institute, again, as a nonpartisan organization, is still fighting on principles. There were several ballot measures all across the country that the Heartland Institute pushed hard against, and when I say pushed hard against, I mean educate voters about what these things are about. There was a carbon tax, a carbon dioxide tax in Washington State. We had lots of writing and lots of input into the voters of Washington State. That carbon dioxide tax was rejected. In Colorado, they had this ballot initiative that would have made fracking impossible in the state of Colorado. It was kind of convoluted. But the rules of the ballot initiative would have made it illegal to frack in Colorado, destroying their economy and not helping the American economy either. That was rejected. In Arizona, they wanted Tom Steyer, the billionaire environmentalist radical, was pouring tens of millions of dollars into the state of Arizona for another ballot initiative. This is to expand their renewable power mandates, which raises electricity rates for everybody in the state. We made videos, we wrote, we were on radio, we did podcasts, and we pushed all that information into Arizona, and they rejected that one as well. So those are the kind of things that the Heartland Institute does. We stand up for principle, we stand up for climate realism, we stand up for lower taxes and free markets. And if you are excited about these things as we are, and you're not yet a supporter of the Heartland Institute, we really hope that you will consider becoming one, because we're not able to do any of these things without the support of many people in this room, many people watching this video either live or later on tape. And so there's information at your tables where you can learn more about joining the Heartland Institute and helping us in our mission. And with that, it is my great pleasure to introduce our speaker tonight, Twila Brase. She is a policy advisor to the Heartland Institute, one of the 500 that we have spread all across the country. She's a registered nurse, and she's the president and co-founder of the Citizens Council for Health Freedom, which is a patient-centered national organization based in St. Paul, Minnesota. In August 2009, Modern Healthcare magazine named Twila Brase number 75 on their list of the 100 most powerful people in healthcare list. In October of 2013, Twila received the 2013 Eagles Forum Eagle Award for Minnesota. In September of 2014, she received the Freedom of Informed Choice Award at the Sacred Fire of Liberty Gala in Maryland. Twila Brase is our kind of person here at the Heartland Institute, that is for sure. And she's also the host of the Health Freedom Minute, which is heard on more than 800 radio stations in 47 states. She's here to present on a book that I saw her present on at Freedom Fest over the summer, and it scared the hell out of me. And I think if it doesn't scare you, because you're a little bit braver than me, is you're at least going to be a lot more informed and want to get out of here with action to do something to fix this major problem that's affecting everybody in America. And that's because it's in her groundbreaking book, Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records. Ladies and gentlemen, please welcome Twila Brase.
Well, thank you. I'm so glad to be here, and I'm so glad that you're all here to listen and learn about what you probably don't know is happening in the exam room every time that you go to your doctor's office, what you probably don't realize that your own doctor is facing but isn't talking to you about. So that's what I'm here to talk about, is this book, Big Brother in the Exam Room. And the very first words that I say in this book are, "The watched are never free." So just think about what it's like when somebody's watching you, how differently you might act or what you might not do if you knew that somebody was watching you. So now imagine having a watcher, a listener, a hidden recorder, a camera, or an always-on Alexa in the exam room. Imagine every word that you say to your doctor recorded and available to millions who are potentially authorized with access to have access to that data under federal law, all without your consent. This is where today's big brother, big business model of medicine is taking us, courtesy of Congress. The professional ethics and patient-first principles essential to the mission-based the mission-based model of medicine has been, let me just start over here. The professional ethics and patient-first principles essential to the mission-based model of medicine have been kicked out of most exam rooms and replaced by the big brother model of business and government. Now why? Because these third parties, business and health plans and government, are paying the bills. As a result, they believe that they have a right to your data, and they believe they have a right to control your doctor. They believe they have a right to control what happens in the exam room, what happens at the hospital, and increasingly, as more patients come home, what happens in the home. So they also believe they have the right to control your doctor and use your own data to do it. If surveillance is allowed to become acceptable within the patient-doctor interaction, Big Brother in the exam room will become Big Brother everywhere, because health is such an essential part of what happens to us. George Orwell was right about where the country was going to go, but he was just a little off on the timing. Today, as you know, we've got computers with cameras, tracking capabilities, and recording capabilities in our homes and in our pockets. How many of you've got one with you? Right? And just 4 years ago, these computer systems became mandatory in every exam room and at the bedside of every patient. Doctors and hospitals that refuse to participate in this surveillance-based command and control system are penalized with reduced payments. I wrote this book because privacy is the foundation of freedom, in and outside of the exam room. But most people haven't connected these two dots. Of course, this is a crowd that has probably connected these two dots. But if you don't have privacy, you can't have freedom. Unfortunately, the American public is so intrigued with technology and big data that I don't believe that they see the big picture. So my book not only exposes the big brother that has invaded the exam room by government design, it also gives the big picture. Part of that big picture is the bipartisan nature of the move to surveillance and outside control. Thankfully, there is some bipartisan support at the legislative level. However, there is twice as much bipartisan support at the legislative level for eliminating patient privacy rights and patient consent rights. Members of both parties are using the legislative process to give government agencies and major corporations broad access to private medical records without patient consent. And I make this very clear, this bipartisan nature very clear in my book. Notably, our organization works with Democrats and Republicans where we can, and we oppose Democrats and Republicans where we must. I am a registered nurse. I spent the first 7 years of my working life working in a pediatric emergency room. And later, when the Clintons decided that they wanted to take over the healthcare system and use managed care organizations, now called health plans, to run it, I helped to co-found this organization. The other thing that was in the Clinton plan was a national electronic medical record system that would be created to also run what happens in the exam room. And it would have practice protocols on it that would tell doctors how to practice medicine. And using the electronic record would decide how many doctors, or would score how many doctors complied with that. So the Clintons may be out of office, but they are very much with us. The plan is very much with us. It was all managed care, and it was all electronic health data systems. And so you might wonder, well, how close are we? Well, consider A third of the Medicare population is in managed care. These are the managed care Medicare Advantage plans. 70% of Medicaid is in managed care. Most employees are in managed care. And Obamacare prohibited real insurance, the affordable indemnity kind, and said that all of us must have health plans, which are managed care, unless you can escape into a health sharing organization, which more than 1 million people have done. Furthermore, the Clinton plan for a national medical record system is halfway established. I have a picture of it in the book. And it's halfway established because of HIPAA and because of the electronic health record, EHR, electronic health record. I'm going to say that several times, so EHR, so just know that that's the electronic health record. So because of HIPAA and the electronic health record mandate, as well as the move to a national ID through the Real ID system, I believe you have that here, and the placement of government-issued practice protocols in the electronic health record today for doctors to use in the treatment of patients. All of these are what the National Medical Record System is meant to do, and all of it was part of what Hillary planned for healthcare in America. Now, we do not have to keep marching down the road that was paved so many years ago. I believe that Americans just have to have their eyes opened to see really what's happening here, and that computer in their exam room is not what they think it is. So my book, Big Brother in the Exam Room, is working to pull these two elements together. One, the fact of managed care and how managed care uses the National Medical Record System and the electronic health record, as well as the mandated surveillance system, and to bring that into clear focus so that Americans do not slip into socialized medicine completely unaware that what they're getting is just American-style socialized medicine run by the managed care plans using the electronic health record and the National Medical Record System. So too many Americans, I think, falsely believe that the electronic health record is the latest whiz-bang technology. And they have no idea that it doesn't even work as efficiently or effectively or handily as that computer in their pocket. And in the process, I fear that what's going to happen is that we will lose access to physicians. I know it's probably hard for you to even imagine, but the question you should be asking yourself is, will there be a physician in the exam room? Is there going to be a doctor in your future? Or will you only get a doctor when you need surgery? Will you only have access to non-physicians in the exam room who will use the electronic health record and the treatment protocols in the electronic health record to decide what you have and how you will be treated? And you won't actually have somebody who has had medical training because they'll just go off the treatment protocols in the record. So I can tell you that physicians are very frustrated and they are leaving. There is a mass exodus of physicians, but most people aren't aware of that. They're very frustrated by the electronic health record, the EHR, and they are fed up with being data collectors for the government and being data reporters to the government and violating their ethical standards and their principles of the patient first in order to get paid. So at least 60.6%, according to a survey by the Physicians Foundation, are thinking of a partial or full exit from the practice of medicine in the next 3 years. 17% are planning to retire. You have any idea how many 17% of the doctors are? It's 103,000. That's a lot of doctors from every state that won't even be available. And some of them will be specialists and some of them won't be. Another statistic is that 54% of doctors consider themselves burned out. And at least one doctor is committing suicide every day. This is a new phenomenon, but it's directly related to the bureaucracy that has consumed the practice of medicine and limited their time with patients and even time with their own families. There's something they call pajama time. And that's when they are at home with their families, but in a different room, doing the documentation in the electronic health record in hopes of being fully paid and getting their performance scores high enough. So I wrote this book so that those who love freedom and want to access excellent medical care far into the future can work together to arm themselves to stop what's happening in the exam room today and to banish Big Brother from the exam room. So you might wonder, how did this happen? How did we get to the point where we used to have, I mean, how many of you remember a time where there wasn't a computer in the exam room? Was not a computer in the exam room? Okay. How many of you only remember there being a computer in the exam room? Right. So in a very short period of time, we have moved from no computers in the exam room to every exam room with a computer. Well, some would say that Big Brother entered the exam room with HIPAA, which I call the no privacy rule, which you probably think might actually protect your privacy, but it does the exact opposite. But the intrusion started earlier, and it started in 1942 when Congress decided that employers could offer you health insurance on a tax-deductible basis as a business expense. And that there began the third-party payment for medical care. So you don't have somebody else paying your life insurance bills, you don't have somebody else paying your home insurance bills, you don't have your employer involved in those decisions, right? But you do, many of you do, when it comes to health insurance. And as I said, they believe that they should be able to control the expenses by controlling your doctor. So that's why I bring up the third-party payment problem on the second page of the book, because I do not want people to miss the fact that the reason that we are where we are today is because we have accepted somebody else paying our medical bills and handed over a lot of our income to health plans who then have the right under law to ration your care away. And then you are forced to pull more money out of your pocket to pay cash if you have enough to someone else. So that's also why I have put a timeline in the back of the book that shows you, starting in 1942 and all the way to 2017, how Congress has advanced third-party payment of care and therefore taken away freedom. But the most visible assault on privacy and on freedom did indeed happen with HIPAA. HIPAA stands for Health Insurance Portability and Accountability Act of 1996. The administrative simplification section of this law came right out of Hillary Care. This is something that Hillary planned for. And out of it emerged the so-called HIPAA privacy rule, which, as I said, did exactly the opposite of what you've been told it has done. Instead of protecting your privacy, it opened up your medical records. Instead of protecting your privacy, it lets oodles of caboodles of people into your medical records to do all sorts of things that have nothing to do with actually treating you, all without your consent. So this was followed by a host of other laws that did things like mandated electronic prescribing. If it was a doctor taking care of a Medicare patient, they have to do electronic prescribing, which means it's trackable. You probably don't think about that when they say, you know, what pharmacy? And you'll say, you know, Walgreens. In some cases, large parts of your medical record are then transferred as well to the pharmacy. I would suggest everybody ask for a paper prescription. Then you can pick and choose which pharmacy you want. You can do price shopping, and you can keep from this violation from happening. Well, after HIPAA and after these other rules came the Recovery and Reinvestment Act, the American Recovery and Reinvestment Act of 2009. Now, you might remember this as the economic stimulus bill. It happened, it was signed into law 4 weeks after President Obama's inauguration. And it was something that almost nobody had a chance to look at. And it's something that was clearly written and planned before he ever got into that role. But within the Recovery Act was HITECH, the HITECH Act. And that stands for, I'm going to make sure I don't goof here, Health Information and Technology for Economic and Clinical Health Act. And that is what included the mandate that every doctor and every hospital had to have an electronic health record in their office. Now, it had to be a government-designed, government-certified electronic health record. So it's designed to do what the government wanted to do, not what doctors and patients needed it to do. And it also had to be used meaningfully. These are called the meaningful use requirements. And part of meaningful use was that it has to share data with the government. It has to ask for this certain information from you. It has to collect certain information and do certain analyses. All of this, or otherwise, they wouldn't receive payment to put this really expensive system into their office. And it's very, very, very expensive. And if they don't use it meaningfully, the government can come back and claw back all that money from them. And this is a huge expense on their part. So now let me just give you a quick overview of the book, Big Brother in the Exam Room. It is a warning to patients, and it's a tool for active engagement, and it's a description of what doctors face every day. And why is that important? Because I think you need to know that when the doctor's looking at you or not looking at you, right? Because the head is turned, hands are on the keyboard, right? You can see the back of the head, he's not even looking at your eyes. And I'm speaking as a nurse. When I evaluated a patient in the ER or I was talking to their parents, I was looking at how their parents talked. What was the body language? What was the pain level? What was many things that you can find out just in that discussion with the patient and what you see, how they say it, the tone of their voice, everything. But now the doctor's attention is in the box. It's in all these check boxes in the box. And I would ask you all, the next time you go to the doctor's office, ask to leave with a copy of that record. Or make a call or send a letter or whatever the next day. Best to just ask for a copy right then and there. And you will be surprised at all the things it says you don't have, because they have to check all of these boxes, and the record gets really long because they have to go through all of these check boxes. So they're thinking about how to get the boxes checked, when you're hoping all they're doing is listening to you, focusing on you, and going to solve your problem. And that's what a physician was trained to do. They were not trained to check boxes. So, and the book is also made, its most complicated chapter or section, I believe, is section 2, which is about meaningful use. And it's complicated because I just wanted patients and Americans just to see exactly what doctors have to think about and wade through in order to get paid and not have reduced payments for every Medicare patient. And so this whole meaningful use section you will see is a bunch of gobbledygook that they have to be concentrated on rather than you. So they are experiencing a lot of pain because of this, and you don't know it. This book is an expose of the government-designed and government-mandated electronic health record that's intruded not only into the exam room, but also into the practice of medicine. Dr. Scott Silverstein, who is a physician, and he's one of the endorsers in my book, he calls the EHR, quote, an enterprise-wide command and control system through which all medical transactions have to pass, controlling clinicians and clinical resources. Now, is that how you think about that computer? Everything has to pass through there for the doctor to get it what they want, but it's all under control of those who input the controls in the computer. It's not under control of the doctors. I also differentiate between the pre-mandate electronic health record and today's EHR. Some doctors had electronic health records they really liked. It worked for them. It followed the workflow of patient care. It was designed for the care of patient. It was designed for what the doctor needed it to do. But today's EHR is government designed, government certified, and government mandated to do what the government wants it to do, and that's why I call it the government EHR. Now, it would be very funny for me to hear back from any of you who go into your doctor's office and say, I understand that's the government EHR. And see if they blink, see what they say. Because they know it's been designed by the government, but they don't think you know. For all you know, it's just in there because they wanted it, right? The main purpose of the government EHR is not the patient, but it's billing, data collection, and reporting. It's also to facilitate the move towards value-based payments for care. Now, I have a sense that none of you know that the plan at the government level and the health plan level is to pay doctors according to the perceived value of outsiders. So it's not for their services, it's not for their skills, it's not for their time, it's not for the equipment that they use, it's not for if they put in a better knee replacement or a poorer knee replacement. It's formulaic. They are going to put in the cost and they're going to put in the quality measures, which are really compliance measures, and then they're going to decide if the doctor gets what the doctor did had any value that is worth being paid for. Now imagine saying this to your plumber. Go ahead, do your job, fix my pipes, and then I will evaluate according to cost and quality, my definitions of quality, whether I think there's any value in your service, and I will pay you accordingly. and your plumber will do what? That's exactly right. Your plumber will turn around and go, right? But the doctors, they've just accepted this because they've accepted Medicare, because they've accepted Medicaid, because they're being trained to be managed care doctors, particularly the newer doctors. The older doctors are still more resistant. So the government EHR is also valuable for ACOs. ACOs are accountable care organizations, and they were established by the Affordable Care Act, or Obamacare. And senior citizens in particular who are on original Medicare are being placed into ACOs without their knowledge. There's at least 9 million senior citizens in ACOs without their knowledge, and they're just assigned, and you don't have to be told. And ACOs are called HMOs on steroids. So they're managed care exemplified. And it requires tracking you, analyzing you, and deep analysis in order to get paid, because ACOs, government wants to pay ACOs by the care of the population, not the care of the patient. They want to give like a lump sum of money that will last a year or 3 years to take care of the population, whoever happens to come in. And so suddenly you become a financial liability because they've got a pot of money, and every time you come in, you're taking from it, right? So they need an EHR to know where you are and where you're going and who you are and how sick you're going to be, and is there anything they can do to intervene in your life to make you a healthier person. And so that's part of what the EHR is going to do. In section 4, I unveil the HIPAA privacy myth, because while the public believes that HIPAA protects their privacy, they have no cause for alarm once they realize that the data is being shared potentially with 2.2 million entities, being shared in the background all the time for all sorts of other purposes. They might get alarmed, and then we can engage them. And in case you still think HIPAA protects privacy, even though I've said it doesn't, which would be understandable given the depth and the length of this deception, Dr. David Brailer, the first National Coordinator of Health Information Technology, said this about HIPAA, and it's on page 147 of the book. Quote, "You can't force a covered entity to give your data to someone you choose, and you can't stop them from giving it to someone they choose." End quote. In fact, the federal government in a 2010 rule listed the entities that can have access without patient consent, and there are more than 700,000 covered entities, which includes doctors, hospitals, health plans, and such, plus 1.5 million business associates, plus, and then in addition to that, beyond the 2.2 million, are all the government agencies that can have access to your data without consent under HIPAA. In the clinical chaos section, I quote a lot of doctors and nurses. I detail medical errors, the dangers of computerized physician order entry, which means the doctors are actually putting the orders in, and then the clinical decision support tools that are embedded in the computers to try to get doctors to practice medicine the way the government and health plans want it practiced. I also discuss various big data plans that use artificial intelligence and machine learning to diagnose and treat patients instead of doctors. And the book has at least 250 quotes because I really wanted the reader to understand and hear from people who are really pushing this. So you hear their quotes, not just what I'm saying that they're saying. There's a section on government intrusion that describes research at the bedside. There's the Obamacare Innovation Center's experiments on patients through the Affordable Care Act, the slice and dice population health analytic programs that are all data-based, the various state patient surveillance programs, the prescription monitoring system that's in all 50 states, ostensibly to limit use of controlled substances. But listen to this, Nevada just decided that all prescriptions would be reported to their prescription monitoring system. Every prescription written in the state will now be part of a government database. I also discussed the errors and the deaths, and the FDA admitting that there have been deaths and harm to patients because of the electronic health record. And in the final chapter called A Few More Things, I talk about the always listening Alexa and the other voice assistants, the Medicare administration's efforts to give you ownership of data, but it's not really what they're doing. One company's plans to use the EHR system to create complete dossiers. They want to know what you eat, how much you sleep, and what your other social factors are. There's the possibility of using blockchain for patient privacy. There's Facebook's attempt to get medical records and match them up with user data in Facebook. There's the ownership versus stewardship of patient data issue, and then again, whether there will even be a doctor in the exam room. And I conclude with what the EHR could have been, and how some say the only way to improve the EHR is to start over. There are 4 lists of steps in the back on privacy, safety, how to get back to privacy, safety, and freedom. 1 for Congress, 1 for state legislators, 1 for physicians and clinicians, and another for patients and citizens. Some of them are the same, some of them aren't. They don't have to be in any particular order. You just have to engage. And there are some really concrete ones as patients. Like, for instance, I say that every time you go into the exam room and the doctor gives you some sort of treatment, you should say, "So, doctor, is this your best clinical judgment, or is this one of the only options available to you in the computer?" And then you will have a better idea of what's happening. So I wanted the book to be eye-opening, eye-friendly, bulletproof, credible, policy-altering, and life-changing. There are 1,547 endnotes, or footnotes if you prefer. It's a lot, but I made it eye-friendly. And so I encourage you to get it. Dr. Jeffrey Singer, a physician, wrote a book review for Cato Institute, and he wrote, "This is the first book to meticulously detail the ways information technology is being weaponized against all of us." And he said everyone should read it, and I agree. Thanks for your attention.
Excellent, thank you. Many of the people here in the room know the rules. Put your hand up and a microphone will find you, because without the microphone, the people on the live stream will not be able to hear you. It would be great if you would share your name so that Twila knows to whom she is speaking. And we will get started right over here.
Hello. My name is Jim Mitchell from Lindenhurst, Illinois. Quite eye-opening. A couple questions for clarification. I use the North Shore University Health System. And when I go in the doctor's office, and this is the question, and the computer, they do all that. So you're saying that the camera, when my doctor logs on, not only the camera comes on, the speaker comes on. So our conversation.
No, thank you so much for that question. I will answer that question about the camera. So this is a really important point. When I said at the beginning, imagine, there actually is an incident, I believe it was in England, where they had a camera in the exam room, which just caused an outrage, right? But Alexa, some doctors' offices are actually putting Alexa in the exam room, and Alexa is always on.
Right.
It's not a camera.
Okay.
Right? And then there are some other voice assistants, or sometimes they'll have somebody outside the room with a more of a hidden microphone, but it's not hidden because they'll tell you, if you want me to, I can turn this off. But they're outside because they don't want to make you uncomfortable. So like some of you probably have had a scribe in your room. They're in there with the doctor, right? Now we got a third person here, and we no longer have a confidential patient-doctor relationship, and this scribe doesn't have to be any kind of particular anybody. They just have to be able to type, right? And so sometimes in order to make the patient feel more comfortable, some offices have put the scribe outside and put a microphone in. But I don't know yet of any cameras here in the United States.
Okay. That was a clarification question. My one question then is, I'm a senior citizen, so I like how Medicare is taking care of me. But if people have bad health behaviors, I don't do these things, but I'm a non-smoker, for example. And so people that we know that are smokers have worse health outcomes. Will there be changes then in the rules or the laws, and this is where the question is, that will affect people who have bad health behavior, and then perhaps the rules will say, we're not going to do so much for you?
So my answer to that is the bigger picture. So everybody in this room has grown up and seen the move from indemnity, which is true health insurance. I had a guy who was almost 80, and he said to me that when he had heart surgery in the early 70s, then his indemnity insurance company sent him a check for $68,000 to pay his doctor and his hospital. And so everything was first party payment, even if you had a true insurance company behind you. Health plans today are not true insurance companies. A true insurance company is just for catastrophes and major medical. And so everything that you did before the catastrophe and the major medical were paid by cash. So you felt it. And so more people were thinking about how to have those bills smaller. So my bigger answer about this is that is where we must go. And the reason why we have a surveillance system and all of this data collection on people and trying to impact their health is because somebody else is paying the bill. A third party is paying the bill, and people don't care because they're not paying the bill. So I do not want to continue to move down that collection of data and that all the direction comes here on the top. What should be happening is people under here are making better decisions because they're paying the bills. And because they're paying the bills, the bills also come down to a level that's affordable. And this is what I feel, I just have to say this, which isn't, Big Brother in the exam room. This is the other part of what we do, which is affordability and Obamacare and the Wedge of Health Freedom, which is an initiative that we started. The price of healthcare today does not have to be the price of healthcare tomorrow. And all you have to do is go and look at the prices at the Surgery Center of Oklahoma. It's a bundled price, it's everything. It's the anesthesiologist, it's the time, it's everything, right? All in one bundle, that's the price. And it's so inexpensive. And the other thing you should do is look at your bills when you have a major bill. A woman came up to me and she said, I had a major procedure, it was $43,000. I looked at my explanation of benefits and I saw that I had to pay, I don't know, it was like $700 something. And Medicare paid $37,000. And she said, and it occurred to me, that's the cost. It said $43,000, but the cost was my $700, and that, $3,700 combined. That's the cost. The cost of actual medical care does not have to be these huge prices that you hear. And it's just so much money shifting happening. There's a lot of fraud. I mean, it's legalized fraud, but it's a lot of fraud. Okay.
We'll go right here.
Hello. My name is Joy Nelson. I have to tell you that Oklahoma Care, I paid $30,000 cash for a broken wrist because I carry no insurance because I'm very healthy. And I looked on their prices, it would have been $6,000 if I had it. And so we need something like that here. But I have a two-part question. One, who is responsible for this? Who are the culprits that put this law into effect, that put it before what, the House or the Senate, and who voted on it? And two, cui bono, who benefits from this? Who cares about all that we do and don't do, and when we sleep and when we eat, and everything we do from birth to death? I mean, this is, what do we do with all that? Why?
Okay, so the first question was, I got the who cares, but the first one, who did it? Who did it? Okay, the work group for electronic data interchange, WEDI, that's who pushed HIPAA, and that's government, big business, big health, big data, big government, all in there. They pushed that, and the bill was bipartisan. It was called Kennedy-Kassenbaum. So Kassenbaum was Republican, Kennedy was Democrat. So, and then when it comes to the electronic health record mandate, that was pushed by, that happened again 4 weeks after Obama's inauguration, so it was all Democrats, but in 2015, with the Republicans totally in charge, they passed another law which embedded it even stronger into law for payment purposes. And everybody who benefits are all the people who are part of WEDI and part of the Health Information Management System Society, which pushed for the electronic health record mandate. And data is the 21st century's version of a gold mine, and they're all mining it.
Raise your hand if you have another question. We're going to go right here to the front.
I'm just wondering when the idea of health insurance came in. Now, I remember a time when I was born, we never even thought about insurance. People didn't have insurance. The doctor came to the house. We went to the doctor's office and we paid like $15 or $10, whatever it was. And now all of a sudden, insurance came about and the huge cost that insurance costs people. Just how did that come about? With the times, what many of us remember who are 80 or more, when times were good and we didn't have high costs. I had my panic sound, and maybe the operation for the hospital was like $100, something like that, even less.
Yeah, so insurance came about, I believe it was really in the 1940s is sort of like where everything happened. But Blue Cross Blue Shield was essentially created because hospitals wanted to figure out a way to get more people into their buildings. And so Blue Cross Blue Shield, you might remember that one of them was, I can't remember which one it was, but one of them was hospital. We'll just say Blue Cross was hospital and Blue Shield was doctor's offices, right? And then they got merged. And so that was really the beginning. But then really when in the 1940s, when they said that employers could offer health insurance and made it a tax-deductible expense, that was really the beginning of doing it on a broad scale, paid by somebody else.
We're going to have two more. The next two are going to be right here at this table.
About 2 years ago, I had surgery on my back. The reason for it, my leg was not performing. There was no pain, there was no issue, there was no secrecy on my part. But I had to make several trips in different directions to get everything going because of the HIPAA laws, which I found stupid. Because I don't need the government secrecy, I need my own secrecy, which is not there. You can put it in the newspaper if you want to spend the money that I had an operation. I really don't care. So why is it necessary that this has to be secret that I can't convey?
So HIPAA is an interesting thing in that, of course, everybody thinks that it protects privacy, and it doesn't. But the other thing is that you're told to stand 10 feet behind the pharmacy counter, right? Or you want to send flowers to somebody in a hospital, and they say, well, we can't tell you if they're in the hospital, right? And you're sure that they're in, but they can't tell you. And we call those the HIPAA hassle factors. They're the things that are meant to make you think that things are private. So that's one piece of it. Then the piece that you're talking about is that there's just a general fear by practitioners and others that they will make a HIPAA violation and they'll be charged a ton of money by the federal government. And sometimes I think they hide behind HIPAA because they don't really know what it means, but they just know that they don't want fines. It's like I tell people, don't sign the HIPAA privacy form or cross out the notice or you're acknowledging the notice of privacy practices, receiving it. And some patients are turned away from care because the clinics are afraid that they'll be charged with a violation. But the fact of the matter is HHS has said, you all don't have to sign it. They even have it on their website, what the doctor's supposed to do when you don't sign it, but they're so afraid. So I think there's a lot of sharing that could happen that doesn't because of their fear, and there's a lot of sharing that does happen because it's allowed and you just don't know about it.
Another one right here.
Two questions. You just mentioned the HIPAA, if you decline it, and you said that some medical offices decline to treat you because of that.
Correct.
How do you handle that? And then also the second part of that question is invasion of privacy. In a recent visit within the last year, and other friends I've talked to, that there's the gun question. Do you own a gun in the home? So, I mean, if you say no or you say yes, how is, what's that invasion of privacy? And, is there a mark? Is there a, what does that mean for future treatment, et cetera, et cetera?
Right. So just as a sort of a all-encompassing umbrella, I encourage you to find a practice that doesn't ask those kind of questions if you can find one. And we have them at jointhewedge.com all around the country. And there are other ones that are available that aren't on the Wedge yet, which is just a map of these different practices. And so one of the things that they offer is true patient privacy. So when you get this, because you can't find that person because there's you have needs and you can't find that kind of person. Now you have to go and be actively engaged. And the unfortunate thing is that you have to go into the exam room on guard. And as a patient, you should never be in this position. The office should be serving you. You should not be serving the office. You should not be, sign our forms and do this or do that, or we aren't going to serve you. It shouldn't be that way. So you have to engage. And so I personally engage all the time. I've only been ousted once. And I did get ousted because I refused. I refused to sign the form. And so one of the things that I do, if you get the iPad, right, the iPad, and the last time I got the iPad, I said I got to, like question 5, and then I decided they didn't deserve question 6. And so then I went up and I said, yeah, I'm not doing the rest of this. And they said, well, you have to do this or we can't register you. And I said, yeah, I don't think so. Figure it out. And so they finally got to the manager, who had to figure out how to bypass all of these questions in order to get me actually registered. And then she comes out to me and she says, well, there's this one thing you have to sign. You have to sign the HIPAA. And I said, yeah, no, I'm not going to do that. She said, well, then the doctor's probably not going to see you. And I said, well, you can go talk to the doctor. And in this case, the doctor knew me very well. And she went back to the doctor, because I heard this from the doctor, that she came in and she said, doctor, we got this patient out there and she's refusing to sign the HIPAA form. And he looked up at all the patients. He said, I looked up. Is it Twila? She said, yes. Yeah, she's not gonna. So anyway, so there are ways, and there are forms. We have forms. And then now the book has the forms actually in it, where the federal government says they cannot refuse to treat you if you refuse to sign. But you should also look at that iPad and not answer all those questions. Just refuse to answer those. Never answer the gun question. There's a whole bunch of questions you should never answer. And why would you tell your office about the entire medical history of your family? Did you know there has been a research project it's a genetic research project. They have taken the emergency contact information of 2 million patients, 2.some million patients, and they have found a total of 5 million more patients. And now they genetically have an idea about the people that you left as emergency contacts. So don't share all that information about your family. And I'm not even doing the emergency contact anymore now that I know that they consider this was genetic research without the DNA. So.
I'm going to make you my emergency contact in the future now, so, get your number. And I think the best answer to the gun in the house question is to, say, if you show up in the middle of the night unannounced, you'll find out the answer to that one. We have a question here in the back.
Hi, I'm Michelle Silby from Glencoe, Illinois. Well, I have a question, but I have to comment on something first, because when I was in the 90s, right around the time that managed care was coming in, I was in a doctoral program for psychology. And in our clinical class and doing differential diagnosis and assessments and all of that for our exams, we had to know, what we were taught more than anything was all the exceptions. Like, okay, this is what the situation is, but you can't put that code in. You can't say that because you'll never get it covered, so therefore you have to lie and do one of these. And it was all of this back and forth. And after a couple of years of that, I thought, this is so unethical. And I remember talking about it with the professor, and he said, yeah, but it's managed care, and there's nothing we can do about it. And I thought, I don't want to do that. So I didn't go into clinical, so I switched. But anyway, my other question was related to the genetic code sharing and all of this. I had thought, like many people, oh, it sounds interesting to do like 23andMe or Ancestry.com, but I research everything. And then I looked into it and I saw the warnings that, oh no, because once you do that, there's supposedly access that they can share and then have that and possibly see if there's a genetic predisposition to something, yada, yada, yada. And that supposedly, they are trying, some people are aware, like you probably, and so they're trying to have that changed where they can't share that. But could you speak to that? I'm curious. I haven't had it done. So.
Yes, I actually did a op-ed in the Wall Street Journal on these companies, and I know it's difficult to look into the fine print, but just look for the words, because a lot of the fine print is actually online. You can look it up and then search for the word third party, because the third party will tell you how they can give access to third parties, and it will start to give some of this exception language. And so I would encourage, the other thing that I would say is they don't actually know what they're talking about. When they give you these results, they may or may not mean what they actually say. So they come out with this, but this, if you look this up, you will find out that it's not so clear cut as some of these companies make it seem about your ancestry. Yeah, or about your DNA. Yeah. Mm-hmm.
All right, we have a question right here. We have time for about 3 more questions.
Bob Johnson, Buffalo Grove. This might be a little bit off topic, but you're discussing the government records with the healthcare. What about all of our records being shipped to third world countries vis-a-vis, I won't mention the NIC countries, but so much of our records, the insurance companies are using foreign labor to process all of this stuff. Outsourcing companies are shipping all the records to other countries, and the rest of the world has your records.
Yes, I don't actually think that's out of the scheme of things here, because, for instance, in the book I talk about a virtual assistant in the exam room that listens, and then that recording is sent to India, if I recall correctly, and doctors in India look at the record to try and make sure whether that's accurate, and then they send it back to the doctor in the United States, who is then supposed to approve that that's what happened in the exam room. And of course, we have no control over India. What HIPAA has is business associate agreements, business partnership agreements, and so those agreements are supposed to say that you control what happens and you limit their ability to do anything with the information. But what are you going to do if people in India start creating a database on people in America? What are you going to do? So, it's happening. Yeah. But I don't think Congress, I think a whole lot of people that should be interested aren't really interested.
They got to get interested, that's for sure.
That's right.
Right over here.
Hi, I'm Larry Greenberg from Skokie. I have really 2 little related questions about the gun question, for example. We have a controversy now about whether the census can ask whether you have a citizen or not in your domicile. Is this question about guns going to somehow find its way to the Department of Labor, to the Department of the Census, where this will be part of our permanent record? So that's one sort of question. The other one has to do with the basics of interoperability. I was under the impression that this whole business would allow, for example, if you went to a specialist at Northwestern Hospital and you had an internist or GP in the advocate system, and you asked for your record to be just transferred because you wanted your GP to know what the result was. That isn't as simple as it's supposed to be. The fields are different. It's not so interoperable. Wasn't that the whole idea of this?
That's a great question. So I'll answer that question first. There was some general language, and I have the statutory language actually in the book about interoperability, and it's very mild kind of language. And because they passed this in 2009 with virtually no discussion, right? 4 weeks after the inauguration, boom, Congress passes it. And they say that as of January 1st, 2014, everybody has to have these in their offices and in the hospitals, or they will get deductions on their Medicare payments. They'll be penalized. And so immediately, all of these new electronic health record companies spring up, because there's a mandate and there's $30 billion that they can have if they can get these, and they knew that doctors had to purchase them. And so there was no push for interoperability, and the language wasn't really strong. And so Congress is kind of coming back after the fact and now trying to impose interoperability on all these disparate systems. But I can say from our perspective, I have a little chapter in here called The Dark Side of Interoperability. The only thing that's keeping HIPAA from sharing your information as broadly as it could be shared is the lack of interoperability. That's the only thing. So yes, you're frustrated about whatever, but they could. Yes. Yes, because until you have actual consent rights over where your data goes, as soon as everything is interoperable, and again, I have a picture of the National Medical Record System as envisioned by HHS. I have a picture, their picture of it in here. Until you have patient consent rights, lack of interoperability is all that protects you from all sorts of things. Oh, and now the census. So the census, you can, if you look up, go to our organization, cchfreedom.org, and put in census. We did a report on census because of how big the census has become and everything that they're asking in the census. And I would just encourage you to consider doing what some people do, which is the only thing that you write, because the only thing that really is required and ever was required by the census is to mark a person, right? So I have had people tell me that they mark one person, and then they write human when it comes to race, and then that's it. And the census has never come after them for that. So just, like, stop the data collection. Don't answer it. Oh yeah, there's a big database. I don't exactly remember now. We did the report. I did the report maybe 4 years ago or so. But there's definitely a database. Yeah. And all sorts of people want access to it. Uh-huh.
We got time for a couple more questions right here, Tony.
Hi, I'm Anthony Ciani from Palatine, Illinois here. So I'll start with a comment because I've experienced India-based information technology companies, and I absolutely guarantee that our medical records have found their way into the most incompetent hands the world has to offer, and whatever nightmare you can imagine happening with your personal data has probably already occurred. Now, I'm going to throw some mud into the water here, because this started a big argument with an acquaintance of mine who is on a professional medical board. And so thanks to the microphones in the office, we've discovered that about half of doctors treating Medicare or Medicaid patients do not consult on them about lifestyle changes and lifestyle habits such as diet, when in fact, of course, they're legally required to do so. And of course, the reason that these studies found was because the doctors just aren't trained in it, and so they don't feel comfortable addressing it. Whereas on the other hand, with that microphone in the office, could we have doctors that are abridging their treatment suggestions or altering their treatment suggestions because they know they're being recorded?
So I guess I would answer that in several ways. The most probably provocative way I'd answer it is whether or not everybody in this room would behave the way the government wants them to behave if we just put a microphone in their workplace or in their home. So that's one thing I would say about freedom is you'll never get perfect with anything. You'll never get perfect, but you can capture people in a surveillance system, but you'll still never get what you want. But the other thing that I would say about lifestyle, et cetera, is if you read this book, what you'll find is how little time the electronic health records now provide doctors to have with patients. And I can't remember if it's in there, maybe not, how little doctors get paid for Medicaid patients. Very little. And so you can have all of these requirements, but they're not really being paid to do it. It's the lowest payment. It's sort of like coercion instead of charity, or an expensive version of charity. So that's one. But the other is that doctors are now spending twice as much time recording things in the electronic health record as they are with patients. And so their time is being consumed to get payment by doing what the outsiders want to have in the record rather than actually talking to the patients.
Right here.
Hi, my name is Lisa, and I just wanted to ask you briefly mentioned about medical sharing services. Can you recommend companies that do that? I know I've heard things on the radio about Christian healthcare and things like that. Are there companies out there that will do this for you and like evaluate your needs and that sort of thing?
Medical sharing organizations are essentially a different version of coverage. It means that every person that is a member of the health sharing organization, which means they pay a share, and their shares go to pay the medical expenses of other members. So they are not, they're not evaluating you. I will, your health. That's what you're saying. Or they evaluate your health or where you should go, that sort of thing. Some of them, they all work differently. Samaritan Ministries, for instance, requires that people send their share to an actual person. And they will tell them who to send the person to, and they will encourage them to send a note to that individual, not just a check. Medishare has essentially an escrow account, and all the money goes into the escrow account from all the shares, and then Medishare itself pays the patients who need their costs covered. So it is a different way of, it's not insurance, but it's a different way of covering medical costs.
Is it something you would recommend?
There are, yeah, it is far less expensive than insurance, and there are more than 1 million people on it now. It is one of the exemptions to the Obamacare mandate and penalty, and so it just caused membership to skyrocket. We have 6 organizations with URLs, websites on our website. And so you can just go to our website, put in medical sharing or health sharing, and you will find a report that I did in 2010. And you will find comparison charts that have been made since that time.
Is that the CCA?
Freedom.org. Yeah. Just search under medical sharing or health sharing.
Okay, last question.
Hi, my name's Victor Dula, and my question is, I noticed in the back you had chopped up into different sections on what the doctors can do and finally what the patients can do.
Right.
And there's a whole bunch of things,
Yes.
but if you had to pick one thing or several things and condense it into one kind of major takeaway, what would that be for you?
I would say that you have to tell the truth about HIPAA to everybody that you know. The publisher of this book read the book and she said, I realize that I've been lied to, and it will be dinner conversation from now on. So the word has to be spread that HIPAA is not what it is, and then you need to actively engage in not helping them with their data collection and encouraging your doctors to get out of this system and just take care of you for cash, check, or charge, so that they are not working for somebody else.
Fantastic. How about a round of applause for our speaker tonight, Twila Brase. All right. She will be signing and selling more copies of the book. You should probably buy a couple copies for your friends. Take one to your doctor. Take one for yourself and one for your doctor next time you have an appointment. And I may think a lot of doctors would even be surprised about what's in that book. Speaking of surveillance and companies tracking you, a week from tonight, November 14th, right here, we're having a free Heartland movie night. We haven't done one of those in a while. So admission is free. We should have pizza and popcorn and drinks. We are screening a new documentary called The Creepy Line. It's by Peter Schweizer, who some of you in this room may have heard of. It is about how Google, the most powerful and largest corporation in the history of human civilization, is tracking your every move on the internet, and how Facebook as well are tracking you and selling you as a product. If you think you know what's going on online, you probably don't really know what's going on online. And so you should be here tomorrow night for this special free event. The filmmakers will be here. We'll be showing the whole movie, and we'll have a discussion afterwards. You're not going to want to miss that. Everybody who's here got an email from us to be here, and so you'll make sure to get another one and bring a few friends. It'll be great to see even more people in here. It's a very important documentary. Thank you all for being here. Appreciate your presence. You can get book signed on the way out and have